On-the-scene coverage of AHA 13 is supported by Janssen Pharmaceuticals Incorporated.
I'm Peter Block in Dallas, Texas, at the American Heart Association annual meeting. With me is Tony DeMaria. Tony doesn't need any introduction. Tony and I are discussing the late-breaking clinical trials that are being presented here at the AHA annual meeting. Tony, let's start with ischemic mitral regurg, a topic that has been around for a long time, and finally a study.
Yeah, you know, that's the most important thing about the study, that it was done, because there's been a real paucity of randomized clinical trials in valvular heart disease. This one randomized a group of patients with ischemic mitral regurgitation to either mitral valve repair or mitral valve replacement. So it was a comparison of the two surgical procedures, trying to answer the question of whether repair really is better, primary endpoint being remodeling LV function, primarily in systolic volume, with the secondary endpoint of recurrence of mitral regurgitation.
You know, we had, in the past, I've had lots of conversations with Robert Guyton, our chief of cardiac surgery, about the fact that mitral replacement, even though it may have a higher mortality at the front end, is a pretty good operation, and yet people have gone to repair. So tell me what the study actually ends up showing.
Dr. Guyton was prescient. In fact, it turned out that there was really no statistically significant difference in left ventricular function between repair and replacement, but that there was less recurrence of mitral regurgitation over the course of 1 year if you replace the valve, more regurgitation with repair, less with replacement.
But even though they had more regurgitation, the outcomes did not make a difference as far as mortality is concerned.
No,
it's sort of interesting,
that's
isn't
correct,
it?
yeah.
Okay, well, so there you have it. So what does that mean for cardiac surgeons and for our patients?
Well, it's interesting because I've been exposed to a different form of thinking, and many surgeons saying that there is no indication for valve replacement any longer, that virtually 100% of mitral regurg patients ought to be able to be repaired, which is a bit more complicated procedure depending upon the nature of the valves. And here I think the data would suggest that replacement is a very fine option, and if the patient has no contraindication, maybe even results in less MR.
Yeah, but ischemic MR is always tough to repair, so we'll see how that all works out. I'm not quite sure we have the final answer yet on this one.
Yeah, probably not.
All right, let's move on. The CORAL trial, renal stenting.
Yeah, very interesting, Peter. You know, there have been 5 randomized trials on the small side that have evaluated renal artery stenting as treatment for hypertension. And in fact, this was the 6th trial. And this trial was aimed to look not only at changes in blood pressure and renal function, which the other trials have, but also looking at clinical endpoints. So they randomized patients to conventional antihypertensive medical therapy versus medical therapy plus stenting, and follow these patients along, and the study essentially was negative for all the primary endpoints.
Yeah, I was going to say, let me make a prediction here. We have 5 previous studies that showed no major difference, and now we have a 6th that shows no major difference. What a surprise. But in fact, isn't there a little bit of reduction in blood pressure in this trial that we didn't see in the other ones?
Absolutely. There was a 2 millimeter mercury reduction in blood pressure, and remember that it was compared to conventional medical therapy. So if a patient couldn't tolerate medical therapy for whatever reason, then in fact stenting probably would be a reasonable alternative.
So it's still an option for patients that have resistant hypertension.
For the appropriate patients.
Okay, let's finish up with ERACE.
ERACE. Now, ERACE was a very interesting study that looked at the ability of angioplasty and stent placement of peripheral vessels to relieve claudication as compared to exercise testing alone. So again, the protocol that was arranged was the group was randomized either into optimal exercise training or optimal exercise training plus stenting of the claudicated vessels, the vessels that cause claudication.
Yeah, this in the background of the fact that peripheral stenting has always been a little questionable, and does it really help and not help and so forth.
Right.
Outcomes?
And here we have a positive outcome.
Finally.
Finally, the patients who got stented had a little higher quality of life, and they were able to walk a longer distance. So in fact, the stenting did add something to the exercise training, and there were no significant adverse outcomes associated with it. So the results of this study, Peter, would be that in the patient with claudication, whether it's aortoiliac or femoral popliteal lesions, that appropriately placed stents produce a benefit over and above just exercise.
So I think we're getting a signal here. You know, there was this controversy. Shall we stent? Is peripheral stenting something we should throw out completely? And finally, now we have something that says maybe this is a good thing. Fair enough to say?
Fair enough.
Okay. We'll be right back.